As our friends, family, and patients grow older, it is not uncommon for them to begin to move more slowly and to begin to have trouble remembering things. They may even from time to time have to rush to the bathroom to avoid an accident. Any of these symptoms on their own, or all three in mild form, may be the onset of old age. They can also be the telltale signs of the onset of normal pressure hydrocephalus.
And I knew I had the problem of some incontinence before, but I've had it for probably 2 years before I got here. I didn't realize what it was.
I reported different things to different doctors because I didn't see them as being connected.
You see, this is the thing with specialists. They treat one little area, they don't look at the whole person. And I didn't think of telling him about my walking problem.
With more than 250,000 people living with NPH in the United States, it is crucial that we as medical professionals begin to look at the ways in which we can improve the methods of diagnosis and treatment of NPH.
Ultimately, the question that I'm trying to answer for my patients is, does it make sense to go through the shunt operation? Most people who come to see me want to get better. I mean, that's easy. That's why they come to see doctors. And most people who come to see me in this age group are afraid of brain surgery, and I think that that's smart. The challenge is to begin to think about hydrocephalus and then figure out what can I do either to assess the patient with a physiologically based test, or can I get them to a center that does this. A lot of neurologists will use a nuclear medicine study called a cisternogram to diagnose hydrocephalus, and in looking through the literature that exists on that and in comparing it to some other physiologically based tests, one of the conclusions that I've reached is that the cisternogram doesn't answer the question that you want to answer, which is, does this patient need a shunt? One of the procedures that I will offer to all of my patients is a standard spinal tap. Really what you want to do is to remove the spinal fluid and see if the patient gets better. And if it's very clear that there's a level of function, even though temporary, that they haven't seen for a long, long time, again, what I think of as the wow response, I think that's enough to say, let's go ahead with a shunt. If it's equivocal, or if the patient feels worse after the spinal tap, low pressure symptoms, then it may be that they need a different kind of testing. And we've seen patients who really didn't get better with the outpatient spinal tap, but when we did our other testing, because it's a longer period of spinal fluid drainage, but at a rate that's not quite as fast, we get a longer effect on the brain and we're able to see the difference. So as much as we can, we try to answer that question ahead of time and see, can we predict that there's some benefit that they will have after the shunt surgery. And if our testing looks like it will, then that's when most people go through with shunt surgery.
It was like a miracle, because she had been there for 3 or 4 days, and he said, well, let's go and walk. And suddenly my wife, for the first time in several years, was able to walk normally.
We have a role that continues after the patient gets a shunt. I know how to use the programmable shunts. There are now 2 kinds on the market, and I will work with patients, and if they're not as good after the shunt as I would like them to be, then we can alter the setting of the shunt to allow a bit more spinal fluid to drain over the long period of time and see how that affects their symptoms. And so I think the adjustable shunt makes this a chronic manageable disease.
Ready? So what we do is, this is a 2.5. I want to start a little bit lower than that. So I go like this. 1.5. And now if I reposition this one, it should tell me 1.5, all right? You see it? Okay. So now I'm done with it. So this is now adjusted at the level that I think is the good initial level.
I said, you've given my life back. And while none of this was life-threatening yet, it certainly reduced my quality of living. And that's the thing I'm seeing coming back. It's come back a great deal, and that, I appreciate that. I'm not going to worry about running 7 miles anymore. I may walk it. I want to. And that will be fine. At my age, I should slow down, I guess.